Welcome to Lesson 3 of the Captain Surgery, CPC Exam Preparation 2026 series from KS Medical Coding Academy. In this lesson, we're focusing on surgical terminology every CPC must know. Understanding surgical terminology is an essential part of accurate captain code selection. A procedure may be described using specific surgical terms, and understanding those terms helps us determine what was actually performed and which captain code family we should investigate. Throughout this lesson, we'll explore important terms such as incision, excision, destruction, biopsy, resection, repair, reconstruction, and different surgical approaches. We'll also look at anatomical and procedural terminology that can help you recognize important differences in CPC exam questions. Remember, terminology is not just about memorizing definitions. The goal is to connect the documented terminology with the actual procedure and then verify the appropriate captain descriptor and guidelines. So let's begin Lesson 3, Surgical Terminology Every CPC Must Know, 2026. Before we begin, let's look at the objectives for Lesson 3, Surgical Terminology Every CPC Must Know. By the end of this lesson, you should understand why precise surgical terminology matters in captain coding and be able to distinguish commonly used procedure terms. We'll also examine terminology related to surgical approaches, anatomical locations, and directional descriptions. Most importantly, you'll learn how to connect the terminology found in documentation with the appropriate captain code family. Remember, terminology by itself does not determine the final captain code. A term helps us understand what was performed, but we must still verify the current captain descriptor, official guidelines, and applicable instructions. Our CPC focus for this lesson is: understand the term right pointing arrow, identify the procedure right pointing arrow, verify the captain description. The goal is not simply to memorize definitions. The goal is to understand how surgical language helps you interpret documentation and approach captain code selection accurately. Let's begin. Now let's understand why surgical terminology matters in captain coding. As a CPC, you need to identify what was actually performed, where it was performed, how it was performed, and the extent of the service. Precise terminology helps connect the documentation to the appropriate captain code family. For example, excision and destruction are not automatically the same service. Likewise, repair and reconstruction describe different concepts, and a biopsy is not automatically the same as complete removal. This is why similar-sounding surgical terms should never be treated as interchangeable. The exact wording in the documentation helps us understand the procedure, but we must still verify that information against the current captain descriptor and applicable guidelines. The AMA describes captain as a standardized language of descriptive terms and codes for reporting medical services and procedures, with each code having a specific description and guidelines for use. So remember our CPC sequence: term right pointing arrow, procedure right pointing arrow, documentation right pointing arrow, captain descriptor right pointing arrow, verify. The goal is not simply to memorize surgical vocabulary. The goal is to understand the terminology, connect it to the documented procedure, and then verify the correct captain code. That is how precise terminology supports accurate coding. Incision, excision, and destruction. Now let's examine three surgical terms that CPC candidates must be able to distinguish: incision, excision, and destruction. First, incision generally means cutting into or opening a structure or tissue. Think of it as cut into. An incision may provide access or open an area, and the exact captain reporting depends on what was actually performed and documented. Next, excision generally refers to removing tissue or a lesion by cutting it out. Your memory phrase is excision equals cut out or remove. The final captain code depends on the documented anatomy, procedure, extent when applicable, technique, and the exact code descriptor. Third, destruction refers to a procedure intended to destroy or eliminate the targeted tissue or lesion. Think destruction equals destroy. The method and target are important, so the current captain descriptor must always be verified. For the CPC exam, remember: incision right pointing arrow, cut into; excision right pointing arrow, cut out; destruction right pointing arrow, destroy. But don't substitute one term for another simply because the procedures involve the same anatomical area. There is also an important Medicare coding point. CMS's 2026 NCCI Policy Manual explains that incision and drainage performed as part of another definitive procedure at the same site and encounter may not be separately reportable. So the key lesson is: term right pointing arrow, what was actually performed, right pointing arrow, captain descriptor right pointing arrow, verify. Always use the current CPT 2026 code set and official guidelines when applying these terms. The 2026 CPT code set is effective January 1, 2026. Now let's look at 3 important surgical terms: biopsy, removal, and resection. First, biopsy generally means obtaining tissue or cells for pathologic examination. The important idea is that the tissue is obtained so it can be examined. The technique, anatomical site, and exact procedure documented determine which captain code should be considered. Next, removal is a broad term. It can describe taking away a structure, device, foreign body, tissue, or another specified item. So, when documentation says something was removed, don't automatically assume that an excision code is appropriate. You need to identify exactly what was removed and how the service was performed. Finally, resection generally refers to surgical removal of a portion or segment of an anatomical structure or tissue. Think of it as removing a portion or segment. For the CPC exam, remember, biopsy right pointing arrow obtain for examination. Removal right pointing arrow take out. Resection right pointing arrow remove a portion or segment. The common trap is treating these terms as interchangeable. They are not. Always connect the terminology to the documented procedure, then verify the current captain descriptor and applicable guidelines before selecting a code. For 2026, use the current captain code set and official guidelines. For Medicare-specific coding, CMS guidance may also apply. Your CPC memory sequence is term right pointing arrow documented procedure right pointing arrow captain descriptor right pointing arrow guidelines right pointing arrow verify. Understanding the terminology is the first step. Accurate code selection requires complete documentation and verification. Now let's compare 3 important surgical terms: repair, reconstruction, and revision. First, repair generally refers to restoring or closing a damaged structure, wound, or defect. For CPC purposes, think of repair as restore or close. The CPT code selection still depends on the specific anatomy, procedure, and requirements of the applicable code family. Next, reconstruction generally involves rebuilding or restoring a structure or anatomical area. Think of reconstruction as rebuild or restore. The exact captain descriptor must be reviewed because reconstructive procedures can involve different anatomical sites and techniques. Finally, revision generally describes a procedure performed to modify, correct, or improve previous surgical work or an existing surgical result. Think revision as modify or correct prior work. Here is an important CPC trap. Repair is not automatically reconstruction, and a prior surgical site does not automatically mean revision. The documentation must support the actual procedure, and the captain descriptor must match the service performed. For example, CPT has specific requirements within its repair code families, including distinctions such as simple, intermediate, and complex wound repair. The exact code should always be verified against the current captain codebook. For 2026, remember to use the current captain code set and applicable guidelines. For Medicare claims, CMS's 2026 NCCI guidance may provide additional reporting rules. Your CPC memory is repair right pointing arrow restore, close. Reconstruction right pointing arrow rebuild. Revision right pointing arrow modify, correct prior work. And the coding sequence is term right pointing arrow what was performed right pointing arrow anatomy right pointing arrow captain descriptor right pointing arrow guidelines right pointing arrow verify. The key is to understand the terminology without assuming that the terminology alone determines the final code. Now let's focus on surgical approaches and techniques. When reading surgical documentation, ask an important question: how was the procedure performed? The documented approach can help us understand the service and locate the appropriate captain code. An open approach uses direct access through an open surgical incision. Think: open equals direct surgical access. Percutaneous means access through the skin, commonly using a needle, catheter, or other instrument rather than a traditional open incision. Think: percutaneous equals through the skin. Endoscopic procedures use an endoscope to visualize or access an internal structure. Laparoscopic procedures use laparoscopic instruments and are commonly associated with minimally invasive procedures involving the abdominal or pelvic cavity. And arthroscopic procedures use an arthroscope to access and visualize a joint. For the CPC exam, remember: open right pointing arrow percutaneous right pointing arrow endoscopic right pointing arrow laparoscopic right pointing arrow arthroscopic. But here is the important trap: do not assume the approach from the procedure name alone. The operative documentation and complete captain descriptor must support the procedure and approach being reported. Your coding sequence is documentation right pointing arrow procedure right pointing arrow approach, technique right pointing arrow captain descriptor right pointing arrow guidelines right pointing arrow verify. Always verify the current 2026 CPT code set and applicable guidelines before final code selection. For Medicare claims, CMS's 2026 NCCI guidance may provide additional reporting requirements. Remember, the approach is part of understanding the procedure, but the documentation and current captain guidance determine the code. Surgical procedure verbs. Now let's focus on surgical procedure verbs. In operative documentation, the verb often tells us the action that was performed. Words such as incise, excise, resect, repair, reconstruct, destroy, drain, insert, remove, and explore can help us understand the procedure. For example, incise means to cut into or open. Excise means to cut out or remove. Resect generally refers to removing a portion or segment. Repair involves restoring or closing, while reconstruct refers to rebuilding or restoring a structure. Other verbs are also important. Drain describes releasing or removing fluid or contents. Insert describes placing a device, tube, or material. Remove means taking out a specified structure, device, or material. And explore generally refers to examining or investigating surgically. But here's the important CPC rule. Do not code the verb alone. A familiar procedure word is only one part of the coding process. The documentation must tell us what was performed, where it was performed, and how it was performed, and we must then compare those details with the complete captain descriptor and applicable guidelines. The AMA specifically advises that all language within a captain code descriptor should be assessed when identifying an existing code. So remember, verb right pointing arrow action right pointing arrow documentation right pointing arrow captain descriptor right pointing arrow guidelines right pointing arrow verify. For 2026, use the current captain code set. The 2026 CPT code set became effective January 1, 2026, and CMS maintains separate 2026 NCCI guidance for applicable Medicare coding policies. The key CPC message is simple: don't code the word alone, code the documented service. Anatomy and location terminology. Now let's focus on anatomy and location terminology. One of the first questions a CPC should ask when reviewing surgical documentation is, where was the procedure performed? Anatomical terminology helps us identify the precise site and understand the relationship between structures. Proximal means closer to the point of attachment or origin, while distal means farther from that point. Medial means toward the body's midline, and lateral means away from the midline. Anterior refers to the front, while posterior refers to the back. We also need to recognize superficial, meaning closer to the surface, and deep, meaning farther beneath the surface. Finally, pay attention to unilateral and bilateral. Unilateral involves one side, while bilateral involves both sides. These terms can be important when determining how a service is represented by the captain code and whether specific reporting rules apply. Here's the CPC memory sequence. Where? Right pointing arrow which side? Right pointing arrow which location? Right pointing arrow what procedure? Right pointing arrow captain descriptor right pointing arrow verify. And remember the common trap. The same procedure does not automatically mean the same code when the anatomical site or descriptor requirements differ. For Medicare coding, CMS's 2026 NCCI Policy Manual includes specific guidance concerning unilateral and bilateral procedures, so Medicare-specific reporting rules should be considered separately when applicable. For the CPC exam, don't guess the anatomical site from context. Read the documentation carefully and identify the exact location that is supported. Your key principle is, read the anatomy, don't assume the site. Then verify the current 2026 CPT descriptor and applicable guidelines before making the final code selection. 2026 Special Point. Verify the exact anatomical site. Now let's look at an important 2026 special point for surgical terminology. Verify the exact anatomical site. When reading surgical documentation, terms such as proximal, distal, medial, lateral, anterior, posterior, superficial, deep, unilateral, and bilateral help us understand exactly where the service was performed. But remember, these terms should not be used to guess the captain code. They help us interpret the documentation, while the complete current captain descriptor and applicable guidelines determine whether a code accurately represents the service. For example, proximal and distal describe location relative to a point of attachment or origin. Medial and lateral describe position relative to the body's midline. Anterior and posterior describe front and back, while superficial and deep describe relative depth. Also pay close attention to unilateral and bilateral terminology. When Medicare reporting is involved, CMS's 2026 NCCI policies may affect how unilateral and bilateral procedures are reported. For CPC exam preparation, remember, where? Right pointing arrow which side? Right pointing arrow which location? Right pointing arrow what procedure? Right pointing arrow captain descriptor right pointing arrow verify. The CPT 2026 code set is effective January 1, 2026, so always work from the current code set and current official guidelines. Your key rule is, read the documentation right pointing arrow, identify the exact site right pointing arrow, verify the current captain descriptor. Never assume the anatomical site simply because a term sounds familiar. Accurate anatomical interpretation supports accurate captain code selection. CPC scenario plus common trap. Let's apply the anatomy and location terminology we just learned with a CPC scenario. The operative documentation states that the procedure was performed on the left distal forearm. However, the coder selects a captain code for a similar procedure involving the upper arm, without verifying the exact anatomical location in the captain descriptor. So, what is the coder's primary error? The coder failed to verify the exact anatomical site before selecting the captain code. The documentation specifically identifies the left distal forearm. The coder should not assume that a code describing a similar procedure at another anatomical site is appropriate. This is an important CPC exam trap. The procedure is the same, so the code is the same. Not necessarily. Anatomical location, laterality, approach, extent, and other descriptor requirements can affect code selection. The AMA emphasizes that when identifying an existing captain code, the language within the complete code descriptor should be assessed. For the CPC exam, when you see a specific anatomical term, slow down and identify exactly what it tells you. Left OR right. Proximal OR distal. Medial OR lateral. Anterior OR posterior. Superficial OR deep. Then compare those details with the complete captain descriptor. Your memory sequence is, where? Right pointing arrow which side? Right pointing arrow which location? Right pointing arrow what procedure? Right pointing arrow captain descriptor right pointing arrow verify. For 2026, remember that the current captain code set is effective January 1, 2026. If Medicare-specific coding is involved, CMS's 2026 NCCI policy manual provides additional Medicare guidance. So the key takeaway is, read the documentation carefully, identify the exact anatomical site, and verify the current captain descriptor before selecting the code. That careful reading can make the difference between a tempting answer and the correct CPC answer. Final summary, surgical terminology. Let's bring Lesson 3, surgical terminology every CPC must know to a close with a final review. We covered several important surgical terms. Incision means cutting into or opening. Excision means cutting out or removing. Destruction means destroying targeted tissue. Biopsy generally involves obtaining tissue or cells for examination. Resection generally means removing a portion or segment. Repair involves restoring or closing. Reconstruction involves rebuilding or restoring. And revision generally refers to modifying or correcting previous surgical work. We also learned that the approach or technique and the exact anatomical site and laterality can be important when interpreting surgical documentation. But there is one rule that should stay with you throughout your CPC preparation: do not code the terminology alone. Instead, identify the documented service, read the complete captain descriptor, review the applicable guidelines and instructions, and then verify the current code. Our final CPC memory sequence is: term right pointing arrow what right pointing arrow where right pointing arrow how right pointing arrow captain descriptor right pointing arrow guidelines right pointing arrow verify. For 2026, always work from the current captain code set and official guidelines. When Medicare-specific coding is involved, remember that CMS NCCI policies are Medicare-specific and should not automatically be treated as universal captain rules. So remember the progression: accurate terminology right pointing arrow, accurate interpretation right pointing arrow, accurate captain code selection. Understanding surgical terminology gives you the foundation. Careful documentation review and verification help you apply that knowledge correctly. That completes Lesson 3, Surgical Terminology Every CPC Must Know, 2026. In the next lesson, we'll move to another critical surgery foundation, surgical guidelines and documentation.